Thanks very much, Mick, for that very effusive and over-the-top welcome. It's a great privilege for me to be here to join you. I have huge respect for public dentistry, for the oral health profession in general, even though I know very little about it, as will probably become apparent to you during the course of this talk. But I don't think there's really anything fundamentally different between the oral health workforce and the general hospital medical workforce, or the general health workforce, in terms of the pressures and the need for redesign. I first got into workforce reform before I moved across to what my medical colleagues still call the dark side of management. When I was a clinician, I was a nephrologist, as you heard, and all nephrologists for their sins have to run dialysis units, and I was always amazed that we had very experienced registered nurses who knew more about dialysis than most of the doctors, but who had absolutely no authority or legitimacy to even order a set of bloods or adjust a dialysis prescription. And that led me into developing the haemodialysis nurse practitioner model, which I'm proud to say is still surviving at St Vincent's and providing really good quality care. And just seeing not only the sustainability benefits of reform, but also the benefits to patient care. And I think that's a really key thing. And if what we do is always around patient care promotion and keep the patient focus there, we won't go wrong with an agenda which also has a sustainability driver. So there are obviously huge drivers for a different workforce. In some of the health professions, there are clearly shortages that are coming, particularly nursing. We know that conventional registered nurses will, in about 10 to 12 years, be in short supply. In a perverse way, we have too many graduates at the moment for the graduate nurse year places, so we have this bizarre situation where some new graduates can't get jobs. There is a pretty good employment situation in nursing at the moment, particularly in the major centres, but the average age of our nurses is in the late 40s or mid to late 40s, and they are going to start retiring. It's interesting that economics plays a big role in the workforce. Nurses used to leave nursing at a rate of 6% per year until the GFC in 2008, when it dropped immediately to 3%, where it's stuck. So people are hanging on a bit, but nursing is a pretty heavy profession. We know that whilst we have increased the trainees, and we're now training more than 3,000 doctors, for example, a year, we are not a self-sufficient nation. We are still importing nearly as many doctors as we are training, even though we're struggling to find intern places for the doctors we are graduating from our universities. And that's mainly, almost exclusively, because the Australian health graduates are not particularly keen to go to remote locations or to rural locations, and that is something obviously will strike a chord with the oral health workforce as well. And it leads to this big challenge that we all face, which is maldistribution. Now, I find it sort of extraordinary that we are, raiding some countries of the world of some of their best graduates to bring them into Australia, both doctors and nurses, and to a lesser extent other professions, when we are probably training enough to meet our needs. Maldistribution is a challenge that nobody has addressed properly, and I know that in the oral health workforce that is one of the biggest challenges we face, because oral health disadvantage is much more prevalent in particularly Indigenous communities and a lot of remote communities. One of the other challenges for workforce reform is this issue of over-subspecialisation. We have got very, very specialised, and there are good things about that, and because healthcare has become incredibly technically complex, and you can argue that we do need people with a hugely specialised background for certain functions and roles and in the system, but people in many areas are becoming so narrow that they lose a holistic appreciation of the patient's situation, and often that leads to much more expensive care and much more fragmented care. And the good example was the demise of general medicine in hospitals, where the elderly person who's got cardiac failure and renal failure and respiratory disease and have had a TIA or something is managed by, it was for a long time, managed by about 6 or 7 different subspecialists with nobody taking an overall view. And we're seeing a significant resurgence in the development of generalism in hospital land, and again, I think there are some analogies in your world of oral health where people become so specialised that they only want to do 1 or 2 different tasks. And that leads, I think, sometimes to what I think is a big driver for reform, and one that's caused me some political trouble when I say this, but I think a lot of our health professionals are actually not very extended and are quite bored in what they do. And if you're what I call a luminal gastroenterologist, for example, the person who sticks telescopes in both ends, and you don't have a significant addition to that by consulting people and treating people, if you're basically doing a simple procedural test most of your week, it's hard to see that you don't feel underextended having done 15 years of post-secondary education and are going to get bored, and that leads to all sorts of perverse behaviours. I genuinely believe a lot of our health workforce, and the oral health workforce included, are overqualified for some of the tasks they're doing, and we could all move to the more extreme end of our scope of practice. But the elephant in the room, and I put this up at the Health Workforce Australia conference 2 years ago, and immediately 12 union delegates tweeted messages of mass destruction on the website. But the other 90% of the audience tweeted positive measures. But the biggest challenge that we have is we do not have a sustainable health system. We cannot, the US has now, in some parts, just hit healthcare as 20% of gross domestic product. Fortunately, we're less than half of that, but we know that all of the demographics are there, the ageing population, that we will not be able to sustain a health system and provide for the growth in demand without some structural change. And we know from experiences around the world, we know from experiences even locally and across the Tasman in New Zealand, that you can structure your health workforce to be a lot more productive than it is now. 75% of the costs in a big health service like Austin Health are salary and wages, and they will always be the biggest element, and they are our most valuable resource. But if we're not using them to the greatest effect, if we're using people to do things for which they're manifestly overqualified for, we're not doing our duty to the taxpayers, because we could provide more services for the same amount of money by doing things differently. I think in your on the bottom of this slide, I've put access for oral health, because I think that's a particular challenge that, and I think Mick referred to it before, in the general health system we do have Medicare, we do have a sense of universal right to access, and in the main, for services other than perhaps some elective surgery services, we do provide pretty universal access, and that's clearly not the case in the oral health industry, and that's a particular challenge that you have where your model of care is still very much a private sector one, and the proud flag wavers of public dentistry are meeting a huge part of the demand, and I take my hat off to you for what you have achieved, and particularly talking to Deb, hearing what's been achieved recently with just a bit of additional money, how the workforce has risen to the challenge and delivered such great outcomes. So, getting back to the sustainability issue, we know, if you look at the general health workforce, in my world, the hospital workforce, the doctors and nurses and allied health professionals, we know that the cost of our health workforce has actually increased over the last perhaps 10 to 12 years, more than the growth in health funding. And we, on many measures, have a less productive workforce in terms of costs for service delivery than we had 10 to 15 years ago. Now, in the last 2 years or so, that's changed a bit as we've had huge productivity demands and a lot of reform and change has happened. But certainly for most of the mid-90s to the late, or most of the 2000s decade, we were growing the cost of our health workforce at about 4% a year, which was much more than the growth in health funding. We have this very strange situation where in healthcare, and I'm probably in the oral health workforce as well, we have this imbalance where we spend, as I said, 75% of our costs on salary and wages, and we tend to often run 10-year-old computers or old equipment, and we don't have our facilities and equipment up to speed because we're spending too much of our budget on the workforce. So my contention is that if we can slow the rate of growth of health salaries in order to free up resources to spend on new service delivery and infrastructure, and without anyone losing their jobs, anyone in the existing workforce losing salary, and in fact a positive impact on the way some people would feel in their workplace by their motivation and the satisfaction they get from their work, why wouldn't we do it? So if you think about it, looking at, this is my world, the world of sort of general hospital land. This is the way, in a simple diagrammatic format, I would see us needing to move. So we have the traditional medical roles, which the top end will always be taken by doctors. But some of those roles could be done by high-level clerical staff. We have junior medical staff in our hospitals who spend sometimes 30% of their time chasing up x-rays, ringing GPs, doing things that could be done by clerical staff. We already have a lot of advanced practice nurses, nurse practitioners doing things like colonoscopy, which I'll come to later. There's like stroke nurses, which you'll hear about later on this morning. A whole raft of those roles, which take those appropriately university graduate nurses to the extent to which their scope of practice can take them. The nurses will always still be responsible for the fundamental delivery of care in the wards, but a lot of that is now being taken on by enrolled nurses who are now able to to dispense medications and to take observations. And they're going to take over progressively some of those traditional ward nursing roles, whereas the RNs will take on more of the coordination of care. Importantly, we are now starting to see an influx, and this is heavily contested space, of an assistant workforce. It doesn't make a lot of sense for every single person who delivers care to a patient in a hospital ward to have a university degree, when 40% of what they're doing is basic personal care, making beds, washing people, feeding them, helping them work. It makes no sense at all to not have at least some proportion of that workforce appropriately and competently trained in the vocational system, working under the delegation and supervision of those nurses, doing some of that personal care work. And that will be probably the way we can cope with what we know is the reduced number of nurses that we'll have in 10 years, but fill in the workforce at the bottom end in an appropriate mix for the care environment that's there. In allied health, we have the same sort of thing happening. And allied health, as you'll hear later this morning, I think from Kath Phillip, is probably a bit more advanced. They're less rigid, perhaps, than nursing, and we already have a lot of well-developed advanced practice allied health roles where we've got people in emergency departments, physiotherapists who are treating people with musculoskeletal injuries without any reference to the medical profession. The doctors know their scope of practice, and it's a structured clinical environment where the doctors are happy with what the allied health professionals do. We have advanced practice physiotherapists who are seeing primarily people with back pain. Doctors don't manage back pain very well at all. If you go to an orthopaedic surgeon, you might wait 2 years for an appointment, and what they really want to know is whether you need an operation or not, and only a small number of people need an operation. If you don't need an operation, you've waited 2 years for not much outcome. So we'd like to see a model where advanced practice physiotherapists see people as a screening, referring on those who can benefit from surgery to surgeons. So that's my world. Now, as I said, I had a disclaimer at the beginning, I know nothing about the oral health workforce, so if I make a blooper, I'm not to be criticised or blamed, although I will take questions at the end. But I see the situation as very similar. You have roles that traditionally dentists have done. You have roles that traditionally the oral health therapists, the dental therapists, dental hygienists and oral health therapists, and you have an assistant workforce. And basically the challenge is simply to say what is sensible for dentists to do, where are those tasks and roles that require the education, training, background, experience and cognitive function of a dentist, what tasks appropriately within the training and scope of practice of the oral health therapist, and how, if necessary, can we extend that scope by further training, further experience, what sort of structured relationship the oral health therapists need with the dentist to maximally use their skill and training. And then we have the assistant workforce and the dental assistants and dental technicians, the workforce that can do a range of tasks, and it's again beyond my knowledge base to say what those tasks are, but it's obviously a very exciting area where we can use the assistant workforce appropriately trained in the vet system to do those tasks that are appropriately done in a structured environment and again in a clinical relationship. So the stretch model is no different. Basically, if we come to the position that in each of these traditional roles we have people who our hugely successful training system have trained to do a range of tasks and have intellectually equipped them to extend that range even, and we are confining them in a rigid environment that doesn't allow them to exercise that full scope of practice for a range of reasons. Sometimes it's turf protection, sometimes it's a regulatory overcoat that might be influenced by turf protection. And if we want to provide more services with the same funding base, we have to make sure that we use our workforce to its fullest extent. So if you go back to my world again, the way I would see it is that the medical profession needs to focus on the cognitive and the complex. The doctors need to use their particular training base where they should be more well equipped to deal with the complexity of initial diagnosis, initial assessment, initial treatment planning. And clearly there are procedural things. You wouldn't want anyone but a medical practitioner taking out your brain tumour. But do you need to necessarily have a neurosurgeon releasing your carpal tunnel, or do you need to have a colorectal specialist doing a colonoscopy? The nurse practitioners and the advanced practice nurses will be doing, as I said, the lower end of the current medical role in a structured partnership relationship, but doing a lot more. There's no reason why, it's like in my dialysis analogy, the nurse practitioners are the people who prescribe the dialysis. They prescribe a range of the dialysis drugs that are necessary, and they monitor the biochemistry, the haematology, and they modify things according to agreed protocols. The dialysis physicians, the nephrologists, then look at the whole patient, the complexity, their suitability for transplantation, their comorbidities, and work in partnership with the nurse practitioners. And everybody is happier. The registered nurses, as I said, will be much more involved in planning and assessment and treatment, and particularly supervision of the enrolled nurses and the nursing assistants. And I've already mentioned that the allied health practitioners are going to be much more involved in assessment and planning and primary response. And in the allied health world, we're seeing allied health assistants now well developed and delivering therapy. A good example in allied health is physiotherapy. It has an attrition rate of close to 30%. So you have physios who go into physiotherapy with an enter score of 99.95, thinking that they're going to be treating elite athletes, and they end up dragging grannies up and down rehab wards, and they get really bored and they leave. And you'll find them in management jobs in hospitals, as pharmaceutical reps doing research roles, because they have a huge experience in dealing with their specialty, but they actually were spending a lot of their time in just delivering therapy, whereas if they could be the people who plan the rehabilitation program and have it largely delivered by allied health assistants who, with their appropriate vet training, are perfectly capable to help Granny walk up and down the ramp in the rehab gym. And that will hugely lead to an increase in retention of physiotherapists, in my view. So in your world, again, I don't know a lot about it, but there's a whole lot of things I gather from sitting on the Health Workforce Australia board that are out there in the ether, sorting out what is scope of practice and to what extent scope of practice should be determined by regulatory boards, what is delegation, what is supervision, what is structured clinical relationships. But it's clear that there are a range of pretty well-defined professions in oral health workforce with a huge and complementary set of skills. And the challenge is to use those skills to the maximum in each of the professional areas. And if I don't know what the challenge is about developing new roles, and in my world we have developed some new roles. I think the challenge in your world is more about using the roles that you have and the training that you have to the maximum. And clearly the dispute's always around the middle ground. And the biggest barriers I'll come to later is dealing with the fear. That fear in the existing workforce, which is always misrepresented as a concern about quality of care. But ultimately the aim is to improve access to services within the funding base that we have at the moment. And that challenge is much more apparent to you than it is in my general health world, although increasingly, having experienced the first gusts of Arctic winds from Canberra, we in the general hospital world are going to be facing the same sort of challenges. So this whole question of what is substitution, what is delegation, what is supervision, you can get caught up in this space, and I'll show you an example in the nurse colonoscopy space where people have got it badly wrong. It's more important to focus on the fact that everyone accepts that healthcare is, and including oral healthcare, is best delivered in a team-based environment. We all know that there are things that people in the team can do best, and people in the team need to get help with, or can delegate or refer off to somebody else. And the key is just that having that trusting clinical relationship and that respect amongst different professions who are part of the team. And that's one of the challenges in reform. Once you've got that respect, people who resist change very rarely continue to resist it. Once they see that the people they're working with, that these new roles, they're actually people that they can trust and work with, their opposition disappears. Generally speaking, if you say, and this is in my world, and I don't know about the oral health world in this place, but where you go and say, well, we're just going to take a role that a doctor did and create a new nursing role, and we're going to do it in isolation from the doctor, and we're not going to be in a structured clinical relationship with the doctor, that will fail. And I could show you an example where it does. On the other hand, if you develop, particularly with new roles, if you develop them in a context of gradual handing over some of those roles in a respectful clinical relationship, where you might require a certain amount of supervision at the early development of those roles, but then over time, when trust develops, that becomes less and less structured and more about what is the clinical need. The worst thing you can do is try and implement a role where somebody is supposedly supervising or delegating a role which they don't support, and they set out to make barriers and block it. And I've seen that happen where people fall back on regulatory barriers and other things to say, well, you can't do that. And the reason they're saying it is not because of the regulatory barriers, because they don't really want the person to do that. And if you haven't got the buy-in of the people who are going to have to delegate the roles, it's not going to be successful. So let me just go through my nurse colonoscopist story, because it is quite an interesting one. We now, Austin Health, we've set up a state endoscopy training program. We're now training 7 nurse colonoscopists. You read about waiting lists in the media. There is a huge hidden waiting list. That's people, endoscopies are not on the waiting list. They're not reported. The Herald Sun doesn't know about them. So we have thousands of people waiting for colonoscopies and these are people who've had those national bowel screening tests where that little kit comes from Canberra that nobody wants to open, and people who might have had a positive occult blood test, or they might have had a family history and they want a colonoscopy. The private sector, you can get it in 2 days. The public sector, there is a huge demand, and we have to have really complex ways of triaging to make sure we make sure people who have an urgent need get done urgently, but people who don't have an urgent need can wait some months. So, we can increase the supply of colonoscopy, but why would we hire, more and more $300,000 or $400,000 a year gastroenterologists to do simple screening colonoscopies to look at people who are almost certainly going to be normal, and do maybe 15 or so in a day, and do pretty much nothing else because we don't have any other work for them. We've got enough gastroenterologists to do the other roles, so it doesn't make a lot of sense. And our gastroenterologists have said that, or at least the leading lights in them have said, well, why can't we take some of these experienced nurses we've got, train some of them up, they can work with us. We're in a big endoscopy suite. There'll always be a gastroenterologist somewhere if the nurse, particularly in the early years of training, finds something that they don't understand or can't manage, and we'll train them up to work in this team-based environment. And so we had to find a clinical champion, and we've got a fantastic clinical champion, Austin, a guy called Reece Vaughan, who's an inspirational physician who is coming solely from a service need. He says, I cannot bear the fact that I can't provide the proper service for my community. So he's trained up these nurses at Austin and now in pretty much every major hospital in Melbourne. And we've got one who's been independent for a year, has done as many colonoscopies as any of the gastroenterologists in the last year, and has the second highest success rate in terms of what we call cecal intubation and polyp detection, second only to Reece Vaughan himself. So hugely successful. Patients are fine. Patients don't, there's a myth about that patients wouldn't want a nurse to do a colonoscopy. A patient want a competent, skilled service provision. That's all that interests them. And obviously over time, he runs his own clinic, he sees his own follow-up. We don't want to say, well, you're only going to do this procedure, because he'll get bored eventually. We want him to be able to have continuity of care, but it's a structured clinical relationship. He knows that he can call on the physicians, gastroenterologist if necessary. And we're starting finally to see access improvement. Unfortunately, we still have to have highly specialised, expensive anaesthetists giving the sedation, but that's not a space that I can afford to go at the moment. But again, that will happen. It's happened. If you look at other countries, you could have a situation, I'll come to that later on, how you could run sedation in a more cost-effective way. So this is what happened in another state, in the north of 2 states north of here, where the chief nurse said, well, we don't want to have these doctors. We want to train nurse endoscopists by professors of nursing in the university. So we're going to bring in 2 nurse endoscopists from the UK, and we're going to set up a course, and we're going to train people using simulation models. They don't actually have any patients, because the patients are all referred to the doctors, and then we'll put them out in the hospitals and they can do colonoscopies, and people will refer to them directly, and they'll manage people independently. And you can imagine the Medical Brotherhood's reaction to that, and it nearly killed off our Victorian program, which was cautiously welcomed by the medical profession because they saw it as something that was safe and controlled and delegated. And that is that's all fallen over now and probably has set the reform agenda back in that state by some years, because the medical profession, who in the main do come from a patient interest need, are going to be very wary about any reform agendas here. So if you think, just to give you a little example, so think about how an endoscopy centre might work in the future. So you might have a big centre in a public hospital that's got four rooms. So you're doing colonoscopies, gastroscopies, and the centre would probably have a gastroenterologist or a colorectal surgeon or a medical specialist of some sort on doing one of those lists and being the sort of senior, and you probably have a specialist anaesthetist too, because some of the people will have complex sedation needs and they'll need that, and if something goes wrong with sedation or a procedure, you need those superb skills of specialist anaesthetists. But the nurse endoscopists and nurse sedationists would probably be doing the mainstream work under that supervision, and the doctors might rove and assist with the complex cases and planning. Now, that's largely a screening centre. You might have a different model if you're dealing with people with inflammatory bowel disease or other disease, where you might have a much more medically dominated model. But whatever model you have has got to be appropriate for the case mix, and it will necessarily be more cost effective. I talked a bit more about how a ward might be structured, just a little idea. At the moment, most of our wards are structured entirely of registered nurses, RNs. So in the future, maybe we'll have a ward which has got a nurse unit manager. Maybe it has some more nurse practitioners, because the junior medical staff, particularly in surgical areas, are not particularly providing the level of service to perioperative care that we have seen in the past, partly because they're often stretched in theatre, and you might have nurse practitioners for each specialty. And we've got one in neurosurgery at Austin who's able to order CAT scans and do a range of things under a partnership relationship with the neurosurgeons. And then the registered nurses will probably still be the major workforce, and they will still be delivering a lot of the care, but they will be also much more involved in care planning and the complex tasks around care delivery. And then you'll have a range of enrolled nurses and vet-trained nursing assistants doing the rest of the work. So the observations and the drugs done by the ENs, and a lot of the personal care done by nursing assistants. We may well have more bodies on the ward, because one thing's pretty clear, and when I talk to nurses, they say, well, we're flat out now. If all you do is replace our RNs with less well-trained people, it's going to make life harder. And I can get that, and sometimes it might mean that we say, well, you are working really hard, but a lot of what you're working hard on is basic personal care, because our patients are heavier and more dependent, and you might be better off having more workers but at a different level, and that might be sustainable. In fact, we've now got 2 nursing assistants in every acute ward at Austin Health, and they're supernumerary to the nursing ratio, but they're cost effective. We actually have not spent more money on them because the nurses are much less inclined to use specials, which is agency nurses that come in at huge premium cost. So that's a little vision of a future surgical ward. And then, the other situation I often talk about is primary care. You go to your GP and you're lucky to get 10 minutes, and that's not the GP's fault. The GP, the whole structure of the practice model is that if they spend an hour dealing with your complex issues, they'll go bust, and there'll be no way to meet the demand. But a lot of what they do, a lot of times you go to the GP might be to get your blood pressure tablets and your cholesterol tablets repeated. Now, that's something that a practice nurse could easily do. There's no need to actually see the GP every time you need a new prescription. There probably is a need to see the GP less often for much longer to explore health prevention, health promotion, even psychosocial issues in a much more complex environment, and leave that routine stuff, the checking your blood sugar or the checking of cholesterol or the checking of your blood pressure, to practice nurses. Similarly, there's a big role for allied health practitioners in primary care. There isn't a funding structure to do that in the main, but people who've come to see the GP with having sprained their ankle could easily be seen by a physiotherapist. So there's a big role, and I think the GPs would be much more rewarded seeing people in more detail, less often, in a more complex environment than just churning people through. So the other challenge that we face in our world I mentioned to earlier is the concept of generalism. As I've said, specialisation is inevitable, it's pervasive, it's really important in terms of providing particular skills. You wouldn't want a radiologist putting a coil in your cerebral aneurysm unless they were a hugely trained specialist neuroradiologist, interventionalist radiologist. On the other hand, you wouldn't necessarily want, if you're an elderly person coming to a hospital with chest pain that's not determined, you wouldn't want the system to say, well, you have to either see a cardiologist or a gastroenterologist or a rheumatologist, and we just guess which one of those is responsible for your pain. You would really like to see someone who can actually sort out what your pain is and look at all of your other issues. And as I said, it leads to some very poor holistic decision making, particularly decisions around end-of-life care, which fortunately you don't face in oral health too often, but we face all the time in our world, where sometimes you've got 5 specialists looking after someone and nobody has the overall picture to say, hey, stop, this patient actually that is dying, and where you're trying to fix the liver, you're trying to fix the kidneys, you're trying to fix the heart, and none of us are working because the patient's dying and because nobody has the holistic ownership of the patient to say that. And that also leads to, excuse me, inflexible work practices where, I'm not going to do that because that's outside of my area. So we've got to think about how we recreate generalism in the hospital world, and one of the things that we're looking at is how we create more hybrids, so how we create people who are maybe do half their job as a nephrologist like my old world and half their role as a general physician. And that helps bring some of those specialist skills into the generalist world. And there's now a huge increase in interest in developing advanced training path in general medicine again. One of the big challenges we face in health services in medical training is that we have structured our trainees according to the needs of the health service. So we say we need 25 anaesthetic registrars or 25 emergency department registrars because that's how we meet our service needs. We haven't thought until recently what that means for those people when they finish their training program, they get their college fellowship, and they haven't got a job. And that's the case. There are anaesthetists in Melbourne and emergency physicians who actually can't get a job. Unfortunately, they still don't really want to go to the bush, although some of them are. And we have to think about that now. We'd much be better off training more rheumatologists who we're going to run out of, and fewer emergency physicians. And if we do that, we have to then meet that service need in the emergency department in a different way, and that might mean more advanced practice nurses and more advanced practice physiotherapists. But we were starting as a nation through Health Workforce Australia to look at a national medical training plan to say, well, we should only be training the number of specialist doctors that we can reasonably employ in the future. The assistant workforce, I think, is crucial. We have become, as a nation, in healthcare, and the same applies to oral healthcare, very dependent on a model that says everyone who deals in a clinical relationship with a patient has to have a university degree. The rest of the world is not in that space, varying degrees of different practices around the world, but it's very clear that there are many tasks in the delivery of healthcare in the broadest sense that can be done very safely and sometimes more effectively by people who have an appropriate training, and the training is crucial. It's got to be properly nationally recognised, it's got to be properly developed, and then that workforce working in a structured clinical relationship with other workers can do huge things and can actually make everybody in the workforce feel more rewarded in what they do. And clearly in hospital land, and I'm sure there's a role in your world too, this is going to be the major growth, and this will be the major sustainability factor for us. If we're going to continue to provide more and more services with a reducing cost base without impacting negatively on the incomes or jobs of our existing workforce, we're going to have to start introducing a vet-trained assistant workforce at the lower end. It's very important that when we do have vet trainees that we have articulation in pathways. So, for example, we now, of our nursing assistants, we've now got half a dozen that have gone on to do EN training. We've got 2 of them that are now actually gone on to do registered nurse training, doing a university degree. And you can bet your bottom dollar that they will be very good nurses and they will stay in the nursing workforce. So, one of the challenges we face is this argument that quality of care will be the victim if you introduce new workforce models. And that is the catch cry of the vested interests, the catch cry of some of the unions, some of the professional associations. They don't really mean it. Deep down, what they mean is, I'm worried, really worried, that these changes will affect my income, or my members' income, my members' jobs, or my job, or my status in the system. Because quality, there's no evidence that these models developed, new workforce redesign models developed in a proper structured, controlled environment, reduce quality of care. There's quite a bit of evidence that they can increase quality of care. And certainly one of the most rewarding things from our nursing assistant program has been the hugely positive response we've seen from patients who are having a number of their care needs met that the registered nurses simply didn't have time to do. And this is the media challenge for governments. You know, if we, you may not be aware of it, but in public residential aged care facilities in Victoria, the workforce is all registered nurses. So you have to be either an RN or an enrolled nurse. Every other state in the country, the workforce is largely vet-trained PCAs or nursing assistants under the direction and supervision of nurses. In the private residential aged care in Victoria, that's the same. But in the public ones, we are not allowed to employ nursing assistants or patient care attendants simply because of an EBA. It makes no sense at all. The quality of care is not demonstrably better, and we could spend the money much better in upgrading these facilities and providing even more staff if we didn't have this ridiculous staffing mix. But every time you say, well, we're going to look at changing the staffing mix, the ANMF will come out and say, well, you're going to have unregistered, unqualified, unsafe staff and they'll kill your grannies. And that's not hard. The Herald Sun will like that story, and it's very hard for ministers for health to counter it. Because people rightly trust nurses and they don't distinguish sometimes the union interest from the professional view of the group, and it becomes really difficult to win some of those battles. Similarly, with the nurse colonoscopist argument in Queensland, rightly the doctors said, well, this is unsafe, and probably it was in that context. So we need to have a strong counter-narrative. So that's why you can't introduce these reforms unless there are champions on the floor, and always have a measurement and a perception and engagement with the consumers or patients, so that their voice is the most strong counter voice. When we produced with our nursing assistant project the evidence, properly documented evidence that the patients thought it was a hugely beneficial initiative, that was the most powerful thing we did to shut down the opposition. And this whole issue of regulation is, regulation is there for a purpose, to protect the community. It shouldn't be there to protect the interests of vested interest. So, as I said, clinical leaders are really important. They are the essential change agents. You cannot introduce reform unless you've got those people. So I couldn't have done the nurse endoscopy program without Reece Vaughan. And particularly important is data. If you can show people data, most health professionals in the broadest sense of the word want to do the right thing by the community and their patients. If you can show them data to show that by doing this change you can treat more people safely, you can often get them with you. I also say to people that if you don't said to the gastroenterologists when I met their leadership group, if you don't buy into the nurse colonoscopy program, eventually someone will do it anyway, like they tried to in Queensland, and they'll impose it on you in a model that won't work and that you'll end up fighting. If you get in at the ground level, you can control the agenda and make it work for you. But as I always said, one of the biggest problems is this peer group fear. I remember talking to and as yet I won't name him, a ENT specialist in a health service nearby, who said that he really supported the training of speech pathologists to do fibre optic endoscopy. You know, they look at swallowing, so they can stick the endoscope in and look at swallowing abnormalities. I said, this is great, you know, can we get you on the national stage? He said, no way, I'm not going out there publicly because the Brotherhood of ENT surgeons will kill me. And it's a real problem, because you often do have these local people who are very frightened, and we see the same with the nurse cystoscopy program. So sometimes you need to bribe people to be into the reform agenda. With the nurse colonoscopy program, you know, Monash Health were not very much in favour until we said we could give them capital money for a new endoscopy centre, and suddenly their philosophical objections, you know, were less, which is good, and they've become huge champions now. You know, local ownership is crucial. So I think I'll come to my last slide. The changes will come, and I think international evidence is growing, and as I think in the next 5 years, you know, depending on what happens in Canberra, and I think, you know, where there isn't going to be the revenue base to do what we do now and meet our current service needs, that our growth without significant change. And as I've said at the beginning, the biggest potential source of productivity improvement is our clinical workforce. Maldistribution is something we've got to look at. We've got to work out how we get people out of the cities into the bush. Local innovation is the key. Something that's imposed by government or by a university on a health workforce will not work. I'm absolutely convinced that consumers are on board with these changes. All they want is quality. They don't care whether you're a doctor, a dentist, a dental assistant or nurse practitioner. They just want to be confident that you give quality of care and that you communicate well with them, because that's what they appreciate as much as anything else. And we need to not get caught up in this issue of regulation. I mean, we've had huge battles with the ANMF about they want nursing assistants regulated. I see no purpose in them being regulated. They only work in a supervised, delegated environment. There's no purpose in creating another huge, expensive overcoat of regulation without any conceivable public benefit. So that's my talk. I don't know whether we've got any time for questions, but if there is, I'm happy to have them. If not, I'll sit down.